Hi guys, so we're here again today for another session, and we will be talking about amyotrophic lateral sclerosis. It's a chronic debilitating disease which is progressive and shortens the lifespan of the individual. We can think of ALS as a common pathway, as the end point, as a constellation of signs and symptoms that we see. But what causes these signs and symptoms are usually what we call dismantling of the motor system, meaning there's affectation of the neurological system, specifically the motor part. And there are various mechanisms that have been postulated to get to this point of dismantling the motor system. And we'll look at about five of them gotten from different sources. Again, research is still ongoing into this condition, and the first one is oxidative stress. And some of them we found as oxidative stress is the cause of damage. And some of them we've seen mitochondrial damage or mitochondrial defect. We've also noticed some autoimmune factor. Again, nothing is set in stone. We've also noticed neurofilament defects. Neurofilaments are cytoskeletal structures that make up the nerves, and we've seen genetic defects too. We've identified some specific genes that may be related, and yeah, basically, so I can think of ALS as a common endpoint with several possible causes, maybe one acting alone or all together. Now, take a hypothetical nerve, a large nerve, a motor nerve, and we can see that the axon is damaged and the cell body is damaged. Looking at the Schwann cell, we can see there's a bit of covering of myelin. Now, as I've said earlier, this is a large neuron. We can see axonal degeneration. And one thing that is unique about this is the damage of the cell body. The cell body is usually damaged, and once the cell body is damaged, the rest of the nerve, the axon, the dendrites are going to undergo what is known as Wallerian degeneration of the nerve. So imagine this happening to a couple of nerves that supply a particular muscle. You're going to have gradual weakness and then death. Just as an addition, the Schwann cells play a role in engulfing some of the axons, putting them into bodies known as ovoid bodies, which are eventually extruded, and the macrophages will come and phagocytose these ovoid bodies alongside clearing the debris of the damaged nerve. So a nerve that was there before, within a couple months or years, it's empty. There's no nerve there. The muscle is atrophied. The muscle is dead, and so on. So let's move on and see what we can get on. Let's see whether we can get a gross picture. What we can expect to see. What we just described is the micro aspects. Now let's look at the macro. Now, like I said, once you have a lot of nerves being damaged, the cell bodies, the axons, and even the covering, you're going to have atrophy, atrophy. So there's going to be atrophy and there's going to be loss of function, and this depends on the part. If it's the brain, you're going to have atrophy around the motor cortex. If it's the spinal cord, you're going to have atrophy at different levels. And if it's the midbrain, midbrain or brainstem, you're going to have different atrophy at different aspects. And this is going to cause a myriad of symptoms, a lot of symptoms depending on the area. Now, if you take a cross section of the spinal cord to the ventral and motor aspects of the brain matter, you're going to see that the ventral aspect, which is actually motor, it's going to be atrophied, signifying the damage to the numerous cell bodies that have aggregated there. Now, the motor cortex is the part that is usually affected. We should note, however, that there are some places that are spared till we get to the advanced disease. And some of those places that are spared are the nerves that supply the extraocular muscles of the eye. That's the cranial nerves 3, 4, and 5. which are the oculomotor, trochlear, and the abducens nerve. Moving on, you also have the areas that control the bowel and bladder function. So you usually don't have bowel and bladder dysfunction till the end. And you have the posterior aspect of the spinal cord, the Clark's column. All right, so let's explore a scenario that sort of buttresses the onset of um, ALS. So let's say we have about four muscle groups, and all these muscle groups are supplied by four nerves, which are four different nerves, which are the branches of one nerve. So that means that you have four different muscle groups being supplied by four individual nerves. Now, with ALS, it's going to be a damage of the nerves. So you're going to have an initial loss of the nerve, but as time goes on, there's going to be regrowth. There's going to be renervation of the muscles that were initially lost. Now, the problem with this renervation is because this is an initial damage, when the nerve is growing back, it's going to be a bit cross. So instead of supplying about four individual muscle groups, you just have one nerve supplying the four as a larger unit. So you have four supplied by four nerves before, and now it just becomes a larger unit supplied by one nerve that is still healing. And this is going to manifest as loss of dexterity. So the fine movements of the fingers and all are going to be lost, and you're going to have weakness because you have less nervous supply to that particular muscle group. So someone with ALS will start with loss of dexterity, loss of fine movements to eventual weakness, and the disease progression comes proper. Eventually, when you have repeated healing and damage, there's going to be an eventual permanent damage to the nerves. There's going to be loss of tonic supply to the muscles. The muscles are going to atrophy or they become spastic, and the patient becomes permanently paralyzed. It's a progressive disease and it just keeps getting worse. A popular person who had this was Steve Hawkins, and he was eventually confined to a wheelchair. Most of them were eventually confined to a wheelchair. Now, the triggers for this are just a few. Smoking has been particularly associated with this, with numerous studies showing this. The other ones include military service, but just stress factors. Research is still ongoing as we speak. Now, moving on, we're going to quickly talk about bulbar and pseudobulbar palsy. So, let's start with the hypothetical structure of the neurologic system, and we'll start from the brain. When you have lesions in the brain, one of the common things you see is emotional lability. That means you have labile emotions, excessive laughing, excessive crying, impulsivity. Now, these symptoms in combination with some other symptoms would give what we call pseudobulbar palsy. It's safe to know that pseudobulbar palsy is an upper motor neuron lesion. Now, let's look at the brain stem. Now, when you have affectation of some of the cranial nerves, like the cranial nerves 9 and 10, responsible for swallowing, you're going to have dysphagia, you're going to have problems with speech. And when you have, these are usually what we call bulbar symptoms, and they are cardinal, they are seen in what we call bulbar palsy. You also have the cranial nerve 12, the hypoglossal nerve. When it's affected, you have tongue weakness, you have atrophy of the tongue and fasciculations. This is also seen in bulbar palsy. Remember what I just said is a lower motor neuron sign. Now, when you have the emotional aspect with these bulbar signs, we call that pseudobulbar palsy. You should note, however, pseudobulbar palsy manifests with upper motor neuron lesion, so you don't have tongue atrophy, you may have weakness. But bulbar palsy is lower motor neuron, manifests with lower motor neuron lesion. Now let's look at some of the signs and symptoms we can find going from head to toe. We've discussed bulbar and pseudobulbar palsy. Now let's look at some other ones in depth. A common one that could be seen is you could have, I mean, varying really. You could have wasting as a lower motor neuron sign. You have weakness, wasting. We've explained the pathophysiology of how that comes to be. And also, we have cramps. You could have cramps and stiffness. It all depends. Now, we've already talked about loss of dexterity and fine touch, but just to re-emphasize, the patient will no longer be able to do fine things like holding your key, like buttoning your shirt, moving your fingers. You're going to lose that dexterity and you're going to have weakness. This has been explained already earlier. We're also going to have paresthesias, dysthesias, general symptoms. And however, I've already said that bowel and bladder function are usually at the tail end of the disease and they connote severity. Note that part of the bulbar signs that you could see is a problem with respiration. There are some that have bulbar onset. When there's bulbar onset and there's problem with respiration, yeah, it connotes a poor prognosis. Now, the classic thing about ALS is that they can present with both upper motor neuron lesion and lower motor neuron lesion. A mixed picture. And that's because it affects everywhere. It affects the brain and the upper motor neuron lesions descending and the lower motor neuron lesions descending. All right, so how do we diagnose? Um, there are some investigations that have been shown to be beneficial. You have nerve conduction studies to see how well the nerves are functioning. We could do an electromyography to see the muscles. It gives the same picture. And we are looking at genetic testing. We've isolated one or two genes, and in the near future, testing could help in a way. But it's majorly clinical. Diagnosis is majorly clinical. We're going to see progressive signs and symptoms, the symptoms that we have discussed. Now, it's only safe to look at how we can manage this. The drug of choice is a glutamate antagonist known as riluzole, but it's not really a Hail Mary pass because it only extends their life by a few months, but ultimately the disease is progressive and it kills. It is a lethal disease. Thank you. If you like this video, kindly subscribe and follow our channels at Dami MBBS. To summarize, we've talked about various mechanisms and how they cause dismantling of the motor system, eventually leading to the clinical phenomenon known as amyotrophic lateral sclerosis. We've talked about the micro features that we see, the damage of the nerve and the axons. We've also talked about the things we see if we take a biopsy of the central nervous system, the lesions, the atrophy that we can see. Talked about the exceptions. We've seen the triggers, smoking, and the other ones that are still questionable. We've explained how loss of dexterity and weakness comes to be in a progressive manner. And we've also seen generally the signs and symptoms, including bulbar and pseudobulbar palsy. We've talked about the diagnosis, which could be helped with investigations like nerve conduction studies and electromyography, and the treatment riluzole. Ultimately, it's been a very good experience, and thank you.